Dear viewers, we are once more welcome to our next two tasks in sepsis management. So the first task was oxygen administration if needed. Now, the next two tasks, we have blood collection for analysis and administration of the first doses of antibiotics. So, first thing, why do we have to send blood for analysis? Why is it important? So, this is going to help us to identify unidentified organ dysfunction that can't be elicited clinically. Remember, we said we can be able to identify if a patient is in sepsis using our clinical clues. But now, there are also going to be organ involvement in sepsis that we cannot be able to identify clinically. So it is important to run these laboratory investigations to collect these blood samples to the lab so that we can identify unidentified organ dysfunction. So that is why we are collecting blood today to the lab. So in this part of management, we'll discuss each blood test and their relevance in sepsis management. So the first blood test that we want to run is the full blood count. And what is in the full blood count that is important for us to see? We have the white cell count, the white blood cell count. And remember, in the white blood cell count, we are talking of 5 components here. The different components, we have the neutrophils, lymphocytes, eosinophils, monocytes, and the basophils. So these are the different components that we want to look at in the white blood cell count. Why is it important? We want to look at the total white cell count, because the total white cell count is going to confirm or refute bacterial involvement in sepsis. This is why we want to look at the total white cell count. And remember, a high total white blood cell count is indicative of inflammation. Remember that a total white cell count is indicative of inflammation. So a high total white blood cell count is going to indicate to us that there is inflammation. And it can rise with many non-infective many non-infective conditions. It can rise with many non-infective conditions like what? Like pulmonary embolism and heart attack. But it is always markedly elevated. This is the difference with sepsis. The total white blood cell count, it is always markedly elevated with sepsis. So that is the difference between non-infective conditions and sepsis. Because with non-infective conditions, you will have a relatively low total white blood cell count. So that is why it is important to run the total white cell count. Now, in the differential white blood cell means that we are looking at the specificities of the different components. In the differential white cell count, it is relatively high. So a relatively high neutrophil is going to indicate or is going to support that there is a bacteria responsible for this infection. So that is why we want to look at the differential white cell count. And a relatively high neutrophil is going to tell us that there is a bacteria involvement. Equally, remember that in early stages of sepsis, the white cell count is going to do what? Is going to increase. Because we need more white cell count to do what? To fight the infection. But with the aggressiveness of sepsis, or with patients that are arriving late in our health facilities, there's a possibility to have what? To have a low white cell count. And when you are having a low white cell count, this tells you that there's an increase in white cell count destruction relative to what is being produced. So when you have patients in the later stages of sepsis, or patients who are arriving with a serious sepsis involvement, we can already have what? A low white blood cell count, because the rate of destruction is not being matched by what? By the rate of production in an attempt to do what? To fight the infection. So this is why we are running white blood cell count. So it's important for us to identify if there is a bacterial involvement or not. If we are having but a non-infective white cell count elevation or not. So that is why we are running this white cell count. The next thing in our full blood count that we want to see is the level of platelets. Remember, when we talk of sepsis, we mean there is an inflammation, and if there is an inflammation, it is obvious that there is platelet involvement, because these platelets are necessary for the inflammatory process. Now, low platelet count, please, low platelet count is a bad sign. It's a bad sign when you have a patient with sepsis. Remember, in the early stages of sepsis, you will have what? The patient is undergoing an acute inflammatory process. So you would discover that the platelets will possibly increase because they are in increased need. But when you have a patient that you have a low platelet count, it is an indication of poor prognosis. Why is it like this? Remember that sepsis involves activation of what? Of the coagulation cascade. Making the blood hypercoagulable means that our blood is going to coagulate, and it is helpful. It is helpful in a situation where there is normal regulation of the system, because what? This coagulation is going to prevent bleeding. It's going to prevent bleeding. But now, when there is dysfunctionality, it is no more helpful. When there is an increase in the consumption of platelets to form thrombi in our blood, in our vascular system, it means there is high consumption of these platelets, and high consumption of these platelets is not matching the level of production of the platelets. And therefore, if you have a low platelet, if our patients come in with low platelets, please, this is a serious emergency, serious condition, serious critical illness in sepsis. And it tells us there's a poor prognosis when you start having this type of a situation. Now, another test that we want to run is the hemoglobin levels. The hemoglobin levels is important. And why is it clinically important? Why is it imperative that we look at the levels of hemoglobin? Remember that oxygen saturation of 100%. Oxygen saturation of 100% means that when you put a pulse oximeter and it reaches 100%, this does not necessarily mean the patient has optimal oxygen content in the bloodstream. So, oxygen saturation of 100% is not synonymous to optimal oxygen content in your bloodstream. Remember, when we are reviewing a basic physiology of oxygen administration, we said oxygen delivery is equals to what? To oxygen content multiplied by the cardiac output. And this oxygen content is mostly dependent on what? On the level of hemoglobin in our system. So if you have a patient with sepsis and there is low hemoglobin, it's but normal that we will have low level of oxygen going to the tissues. So it is imperative that we run the hemoglobin levels to be able to see a patient who is profoundly anemic is going to possibly have a high saturation level, but this doesn't denote high oxygen content in blood. So this is why we want to run the hemoglobin levels. Other additional tests that we can run include maybe urea and electrolytes to also look at kidney involvement. Remember, the kidney is involved in what? In regulating electrolytes. It's involved in what? In eliminating urea, byproducts of metabolism from the system. So looking at these values in blood is going to tell us the level of kidney involvement in sepsis. Also, we can look at C-reactive protein, which is an acute inflammatory protein that is secreted when we have inflammation. And C-reactive protein is elevated in conditions causing chronic or acute inflammation. Measurement of C-reactive protein is going to help us to confirm a likely inflammation. Rather, it doesn't confirm infection. So, trends over time can help us to determine whether the treatment we are giving to our patients is effective or not. Means that we can run C-reactive protein subsequently in patient management to see the effectiveness of our treatment. Remember, when there's an infection, there is inflammation. So, other samples that we can collect to the lab involve maybe sputum to look at the respiratory involvement. If the patient is having, we are suspecting a respiratory tract infection, or we can collect urine. If we're suspecting kidney involvement, cerebrospinal fluid, if we're thinking of a nervous system involvement, or we can collect pus from a draining wound to look at the bacteria involvement with the sepsis. So these are the few tests that are important, and we can run them in our different clinics, in our different hospitals, in our different health centers. What we need is simply the knowledge, the will, and the basic skills. This is all it takes for us to manage sepsis appropriately. And the next task that we identified in the 5 tasks of patient management was giving intravenous antibiotics, administering intravenous antibiotics. So, antibiotic choice, the choice of antibiotics should be guided by the suspected focus of infection. Means that we will not just be administering antibiotics because they are antibiotics, but this should be guided by what? By our clinical judgment on the focus of the infection. So it depends on your clinical evidence of the infection. Remember that we are still sending blood to the lab. We send blood to the lab, and the first hour we want to make sure that we administer the first doses of antibiotics. So if you are confident about the source of the infection, then the antibiotic choice should be tailored to cover the likely infection. If you are confident. But if you are less confident about the source of the infection, then a broad spectrum agent should be considered. Now, culture and sensitivity tests are critical in patient management. It helps us to review the results of this culture and sensitivity so as to do what? So as to reduce antibiotic resistance and toxicity in our patients. It's not good to be administering antibiotics haphazardly. But when we run culture and sensitivity, it is going to reduce the likelihood of resistance and toxicity in our patients. Bearing in mind the common sources of infections in our communities, in our localities, a broad spectrum beta-lactam, for example, penicillin clavulanate, cephalosporins like ceftriaxone or cefotaxime, plus or minus an aminoglycoside like gentamicin, also considering anaerobic involvement using, for example, metronidazole, is a good starting point when you want to consider antibiotic treatment. It is important also to remember that not all sepsis is caused by what? By bacteria. Therefore, certain risk factors should be prompt consideration of what? Of antifungal treatment. For example, those of patients, there are some of our patients who are in the wards who have been receiving multiple or prolonged antibiotic treatment or courses. It is important to consider them as risk factors, and there are risk factors to fungal infection. So you should consider administering an anti-fungal treatment. And after all these interventions, after we must have resuscitated our patient, it is important now to do what? To eliminate the source of the infection. So after the antibiotic treatment, after the resuscitative interventions, consider completing the source control. Consider alleviating the source of the infection. So hello viewers, that is all we had for you in relation to the task of blood analysis and intravenous antibiotic treatment. So our next task is going to tackle what? Intravenous fluid administration. We'll look at the different fluids that we can administer, their reasons for administering, and their benefits in sepsis management. So stay tuned and stay updated with the latest that we have for you. Have a nice day. Bye-bye.